I can hear you, yeah. I can't hear Stuart. I don't know if I'm supposed to. Okay. I feel very blinded. I look like I've got a tick. Ooh. Oh no, what? Yeah. Okay. Hello, Birmingham. So for those of you who were here last year, you may have seen us present the optimization of Sheila, one of our CRT implant patients. Sheila is a lady in her late 70s with ischemic cardiomyopathy who had been getting progressively short of breath, but soldiered on until she could no longer keep from the beginning.
Technology.
Okay. Hi, Birmingham, for the second time. So for those of you who were here last year, can they hear? Yay! Okay. Third time lucky. Okay. So for those of you who were here last year, you may have seen us present the optimization of Sheila, one of our CRT implant patients. Sheila is a lady in her late 70s with ischemic cardiomyopathy who had been getting progressively short of breath but soldiered on until she could no longer keep up with her dance classes. She was diagnosed with severe LVSD, NYHA3 and an ECG showing a broad QRS, and she then had a CRT-D implanted. This was the point where I started to realise how important optimising a CRT device was. Earlier in my training, I was focusing so hard on learning how to implant a device that it hadn't occurred to me that out-of-box settings on a CRT were not optimal. I had the pleasure to work with her at HRC last year and spent some time with this lady, and it made me appreciate the significant lifestyle improvement this lady experienced with CRT therapy, and then with personalised CRT therapy. So to recap on our ECGs, and hopefully you can see them on the screen, the baseline on the top left shows a broad QRS with left bundle branch pattern, and that is her baseline ECG. On the right, this is the out-of-box settings, which narrowed the QRS, but we then personalised her programming further to create the narrow ECG result that you can see on the bottom. And as I'm sure you will all agree, we think this is an excellent result. So after HRC, Sheila was invited to... Yep. Okay. Okay, so we're going to go back to her ECGs. Sorry about that. So the baseline ECG on the top left shows a broad QRS with a left bundle branch pattern. This is her baseline ECG before she had a CRT-D put in. On the right, this is her out-of-box CRT-D settings, which did narrow the QRS somewhat, but we then personalised her programming to create the really narrow ECG and the final result that you can see on the bottom. And as I'm sure you will all agree, we feel that this is an excellent result. So after HRC, Sheila was invited to share her patient experience at an international conference. Hearing how well she felt after her CRT and how she could now go to the shops, go to Wales dancing with her friends was absolutely an amazing experience. It may sound like a cliche, but the reason I went into medicine was to help patients and to treat them so they feel better. And personalisation of CRT gives us the opportunity to elevate patient response and to maximise how well they can feel. This really hit home at the conference when Sheila was able to walk around Monaco with myself with very little effort, a place she had always dreamt of visiting. This lady clearly moved from an NYHA3 to an NYHA1 with personalised CRT therapy, and she's continued to do well. So my name is Jen Middleton. I am a cardiology registrar training in heart failure and devices, and I work at the Northern General Hospital in Sheffield.
And hello, my name is Ashley. I'm a highly specialised cardiac scientist at the Northern with a special interest in complex devices and as part of that, I lead the CRM research in the unit. So the Northern General is a teaching hospital in Sheffield with a large cardiology and cardiothoracic unit. We provide complex device and PCI services to the city and the surrounding areas, which is a population of just under 1.4 million people. Our department also offers more specialist services, such as subcut ICDs, leadless pacemakers, TAVIs, and cardiomem implants. So Sheffield, for those of you who don't know, is in South Yorkshire and is the 5th biggest population in the UK, and approximately a third of the city is situated within the beautiful Peak District. We are famously known as the Steel City. We're home to the oldest football club in the world, Jessica Ennis Hill, the Full Monty, and a personal favourite, the Arctic Monkeys.
But enough about Sheffield. What are we planning to achieve this afternoon? We plan to talk to a patient who has recently had a CRTD implanted at the Northern General Hospital. We will then discuss his history and then run through the optimisation process. We will discuss, I've said that already, sorry. Based on QRS duration and characteristics, we will explain our choices as we go. The goal is to give him the maximum amount possibility of achieving the most out of his CRT with respect to symptoms and LV remodelling. This process, as well as optimal heart failure management and medication, should give him the best outcome that the patient can get. With regards to response, we shouldn't look at this in a binary way. For example, if you had a 42-year-old male non-ischemic cardiomyopathy with a broad left bundle branch block and normal sinus rhythm, you would be expecting an excellent response with CRT. In contrast, a 78-year-old woman who had ischemic cardiomyopathy and atrial fibrillation, you would hope that she would feel better, but you wouldn't expect her to feel as good as the first patient had. Both are technically responders, but we should expect more from the first patient, showing we should therefore strive to achieve a personalised response for each patient and not just accept some improvement in response if we think there is more that can be done. So this is Mr. Ayub, and we're very grateful for him coming today to talk to us. He is a 59-year-old gentleman who has ischemic dilated cardiomyopathy. He's previously had a number of myocardial infarctions with PCI, and unfortunately also an episode where he had stent thrombosis, and that was early in January 2018. His echo showed severe left ventricular systolic dysfunction, but he had a narrow QRS with first-degree heart block. An ICD was discussed at that point in 2017, and Mr. Ayub elected not to proceed at that point. As you should be able to see on the slide behind me, Mr. Ayub is actually on optimal medical therapy for him at the moment. Entresto was added in the summer of 2018, but he did not feel any symptomatic benefit from this. Ivabradine was added as Mr. Ayub was intolerant to higher dose of beta blocker as he had significant hypotension. In 2019, Mr. Ayub's NYHA gradually declined, and he is now, was in NYHA 3 with an exercise tolerance of about 50 metres on flat ground, and a decision was made to go forward with CRT. I'm going to ask Mr. Ayub a couple of questions just to get an idea of how he felt before his CRT and how he feels after. So, Mr. Ayub, thank you once again for coming to see us. So, just tell me a little bit about before you had the device, how were you feeling? What kind of symptoms were you having?
Well, main problem was short of breath.
Okay.
And I couldn't walk any further than 50 odd yards or something like that. And having pain on my left hand side all the time, just a little pain.
I'm going to stand here because I don't think people can hear you. So if you just talk into my mic, if that's okay. So you could walk about 50 metres.
That's right, yeah.
Yeah. Okay.
And I keep having pain on my left hand side. Uncomfortable night, I couldn't sleep.
Mhm.
And that was the main problems.
Okay.
Since I had this pacemaker placed in me, I realized that it's more comfortable.
Mhm.
I can walk a little further than what I usually walk.
Yep.
And can sleep comfortably.
Good.
Much better now, thank you.
Fabulous. So in case you didn't hear what he said, he was saying that before he had his device put in, he could walk about 50 metres. He was struggling to get out and do the things that he wanted to do, and he would find it uncomfortable to sleep at night when he lay flat. Since he's had his CRTD implanted, he's now able to walk about half a mile on the flat with no problem, a bit further if he takes his time, and he's now able to go out and see his friends and do the things that he wants to do. And we have to take into account the fact that this was only done in August, so it's still, a very recent device, and he's obviously getting some good symptomatic benefit from his device. So that's all good. So Ashley's going to tell you about his implant procedure and what happened there.
So Mr. Ayub had a left-sided implant, 3 auxiliary punctures were made using a micropuncture technique. A single coil Durata lead was positioned in the RV, so at Sheffield we mainly use single coil ICD leads. And the CS was cannulated with a deflectable decapole EP catheter. So an Abbott 135 catheter was used to deliver the LV lead to the lateral branch. The lead was an Abbott 1458QL quartet lead to make use of its wide-spaced electrodes, as we had a good vessel length and the diameter through to the apical area. So this gives us more choice of bracing site and may help maximise options with advanced programming considerations. Phrenic nerve was noted distally, and the QLV was in excess of 90 milliseconds. So not the latest QLV, and ideally we would like it a little bit later, but in terms of anatomy for target veins, there were no other viable options. So a question for the panel now: do you guys utilise the micropuncture technique in your centres, or do you have any thoughts of any other aspects, such as the use of a DECA or an EP catheter? Do you guys routinely do QLV measurements? Over to you.
Sorry, say that again. Okay. It's a technique that no, you're fine. Okay. They've never heard of the micropuncture technique.
Okay.
Okay.
This bit's bizarre.
Mhm. Okay. So here is Mr. Abe's chest X-ray. We're just looking at the lateral chest X-ray now, and we can see that the distal electrodes are more inferior, whilst the proximal electrodes are in a midpoint between the superior and inferior. We will return to this later when we look at the 12-lead ECG of LV pacing. The RV lead is placed in an apico-septal position, and we're now going to look at his baseline 12-lead ECG. So you should be able to see his 12-lead ECG now, showing a left bundle branch block with a QRS duration of 175 milliseconds and a PR interval of 220 milliseconds. So I'd like to ask the panel or the audience in Birmingham, have you any thoughts at this point about the ECG? Thanks, panel. I'm sure you had a very good conversation about that, although we can't all hear you over in Sheffield. So before we get into optimising Mr. Ayub's device, we think it'd be really useful to ensure that we know where his LV lead actually is. We know where the lead was left at implant, but is it still there or has it moved? And how can we tell in a pacing clinic why it's important?
So now let's look at some clinical evidence. So this group assessed the impact of segmental LV lead position on CRT outcomes. They took 115 patients undergoing CRT and followed prospectively. Segmental LV lead position along the longitudinal axis, so apical, midventricle or basal, was determined retrospectively by examining coronary sinus venograms and chest x-rays. The primary outcome was a combined endpoint of heart failure hospitalisation, cardiac transplantation, or cause mortality. Secondary outcomes included change in NYHA score and the degree of LV reverse remodelling. So looking at the results, patients were divided into two groups based on LV position. So there was apical or basal midventricle. During follow-up, event-free survival was significantly lower in the apical group. The adverse impact of apical lead placement remained significant after adjusting for clinical covariates. So the apical group also experienced less improvement in NYHA, functional class, and less LV reverse remodelling. So to conclude, apical LV lead position is associated with worse CRT outcomes, and preferential positioning of LV leads in the basal midventricle segments may improve outcomes. So a second publication, utilising the MADIT CRT patients, displayed LV leads positioned in the apical region were associated with an unfavourable outcome, suggesting that this lead location should be avoided in cardiac resynchronization therapy. So now we've showed you the against, I need to talk about the for. So this is some data from a study done in Birmingham that seems to suggest the reverse. In this study of real-world clinical practice, an LV apical position was associated with lower cardiac mortality than non-apical positions, and a neutral effect was observed with respect to total mortality. So over to the panel again. Do you have any thoughts on this apparent mismatch in results of these papers? Oh, so like now. So what do the guidelines say? This is from the ESC guidelines, and it advises to avoid apical pacing sites and targeting the latest activated LV segment, so i.e. QLV targeting. So in light of that information, let's go ahead and attempt to identify where we are pacing from in the LV using a model from Van Dersen's paper in 2014.
So to determine where the lead is based on a 12-lead ECG, we need to pace LV only. Initially, I would look at V1. If this is positive, we are pacing the lateral wall. If this is negative, we are in a septal area, potentially anterior or middle cardiac vein territory. Secondly, I would look at AVF to determine the circumferential position. In AVF, the positive pole is at the foot, so a negative AVF indicates that wavefronts are moving away from the foot, therefore we are in an inferior position. If AVF is positive, we are in an anterior position. Equiphasic means it's in between inferior and anterior. Finally, we look at the electrode position in the apicobasal position. We are looking for the transition point, i.e. the point at which the ECG changes from positive to negative. The later the transition, the more basal the pacing site. So let's introduce some audience participation.
So over to you, Birmingham. Where is the LV electrode? So guys, I hope you're all listening to Jen and got that right. I don't actually know what you've said because I can't hear. But we'll now work through it anyway, using the 3D model and see if we agree with your judgment. So as we can see, V1 is positive, so therefore lateral. AVF is negative and therefore inferior. And the transition happens early in V4, so therefore in an apical position. So this means our electrode is infralateral and apical, and according to the ESC guidelines, not somewhere we should pace. So interestingly, this patient, who's not Mr. Ayub, was a non-responder to CRT.
So I think you've lost sound on Ashley's mic, so I'm just going to take over for a second while we sort it, sorry. So basically this means that our electrode is infralateral and apical, and according to ESC guidelines, not somewhere we should pace. Interestingly, this patient is not Mr. Ayub, was a non-responder to CRT. So now we're going to go back to Mr. Ayub. So here we're pacing at D1, i.e. the most distal of Mr. Ayub's LV lead electrodes. V1 is positive, which means it's lateral. AVF is negative, which means it's inferior. And the transition point is at V2, meaning it's basal. Pacing here, V2, that doesn't make any sense, V4. So pacing here would not be in compliance with ESC guidelines. The next ECG we're pacing at M2, moving a little more proximal. V1 is positive, which means it's lateral. AVF is negative, which means it's inferior. And the transition point is at V3, meaning it's apical. And pacing here would not be in compliance with ESC guidelines. Here we're pacing at M3, moving a little more proximally. So V1 is positive, which shows it's lateral. AVF is equiphasic, which means a mid-circumferential position. Transition is at V5, which means mid-LV. Pacing here would be in compliance with ESC guidelines. Here we're pacing P4, now the most proximal electrode. V1 is positive, which means lateral. AVF is equiphasic, which is a mid-circumferential position. And the transition point is at V6, so this is basal LV. So again, pacing here would be in compliance with ESC guidelines. And now we're going to take you through the personalisation process step by step.
So I'm just going to do a check. Can you hear me now?
Can they hear Ashley? So if you go up there, they'll sort your mic.
Okay.
So first up, this is a 12-lead ECG with Mr. Ayub's CRT device, set up as it would have been at implant with default settings. In this case, pacing at D1 with an AV delay of 150 milliseconds and a VV offset of 0 milliseconds. So while we get Ashley back up with her technology, we thought we'd go back to the panel or the audience to get your thoughts so far on the out-of-the-box CRT settings that we've seen on this ECG. Okay, thank you. So our thoughts are that we can see a narrowing of the QRS duration at 154 milliseconds from 175 milliseconds, but we still think there is a left bundle branch type pattern. We feel that we need more of a contribution from the LV lead and less of a left bundle branch pattern. Now we can look at trying to optimize this man's CRT device. We have started with a QRS duration of 175 milliseconds, and we are looking to create a significant narrowing of the QRS duration and cause some morphological features consistent with good CRT. Ideally, I would want to see a narrower QRS with features that indicate LV contribution, or in other words, I want to see his ECG normalise. So I'm going to hand back to Ashley, who hopefully now you can hear, whilst I get on the programmer and show you what we're going to be doing.
Could everyone hear me? Has it gone through now?
Okay, so I still don't think you can hear Ashley, which is not ideal, but there we go. So, fine. So I was going to do the programmer, but I think if I'm going to talk to you, we might swap places and Ashley might do the programmer, if that's okay. So, Ashley, if you could take us to the CRT toolkit and perform a QLV measurement, please, that'd be really helpful. So for those of you that aren't sure, this is the time it takes to activate the LV lead after first activation of the RV lead, i.e. the electrical delay of the LV lead. We would typically want this to be a value in the final third of the QRS duration, as there is an evidence base that suggests a long QLV is a good marker for patient response. We should be mindful, though, of not pacing an LV scar. This can be pro-arrhythmic and may be characterised by very late QLV measurements or a very wide LV paced QRS duration. If possible, a cardiac MRI scan to determine optimal lead positioning or areas of scar would be very useful in the ideal world. So hopefully you can see the QLV measurements on your screen. We'll just pop them up a little bit bigger for you. So as you can see, we've got distal tip at 61, going all the way up to 76 on the proximal electrode. So not quite as long as we would like, but also not bad. So we're then going to move on to perform the threshold tests. And we can do this by choosing all 4 electrodes to RV coil, i.e. unipolar, as this reduces the risk of anodal rather than cathodal capture. For example, if you chose 1 to 2, then you may be capturing on 2, or you might be capturing on 1. And it's really difficult to determine actually which one you are capturing on. Whereas 1 to coil, you can only capture on 1. And likewise for phrenic nerve stimulation testing, it is worth testing unipolar, as otherwise there is a chance of anodally stimulating the phrenic nerve. So in this case, we're aware that Mr. Ayub has phrenic nerve stimulation on M2, so we've avoided pacing at that site. So whilst I've been talking, Ashley has been putting in our thresholds and putting in phrenic nerve stimulation. And now that we've done all the tests, we're going to go ahead and program optimal single point pacing. And we do this by choosing the point of latest activation, i.e. the longest QLV, with a threshold of less than 3.5 volts with no phrenic nerve stimulation. Next, we would like to optimize the AV and VV delay. In this device, that is using QuickOpt. And Ashley's going to run the test for us now. So this algorithm attempts to give us an optimal AV and VV delay. For AV delay, it measures the P-wave duration to find the AV delay that allows optimal LV filling. And for VV delay, the algorithm attempts to cause LV and RV wavefronts to meet at an electrical midpoint between the RV lead and the selected LV electrode. So you should be able to see the programmer. You can see it's just taking a second to give us the results. I would get Ashley to tell you what they are, but no one can hear her. Okay, so if you give us a second, then we'll be there. So this is real life, isn't it? You know, measurements take a little bit of time and aren't conveniently there when you need them, but there we go. So we have got an optimal paced AV delay of 190 milliseconds and a sensed AV delay of 140 milliseconds with simultaneous LV and RV. So let's program that, and then we're going to take a look at the resultant ECG. Okay, Birmingham, what do you think of our work so far? Excellent. So we agree. We think there is a really good improvement moving away from the left bundle branch pattern and a QRS duration of 120 milliseconds. And if we consider the combination of the AV delay and the VV delay, in this situation we have an AV delay of 150 milliseconds. And in this device, this means that we pace the LV and the RV simultaneously at 150 milliseconds. So we could stop there. It's a very nice ECG result, but we want to know if we can do better. And is there any evidence to try and get better? So I'd like to introduce this interesting paper from October last year. This retrospective study covering 9 years included 552 consecutive CRT patients. The endpoints were death from any cause, urgent transplant, or hospital admission for heart failure. ECGs were measured at 100 millimeters per second, and global QRS duration pre and post CRT were measured. At the Northern General Hospital, we have EP recording systems in all our device implant labs. This makes it really easy to create and measure 12-lead ECGs at high speed to improve accuracy in our measurements and in turn improve patient outcomes. As displayed in figure 2, this study concluded that QRS narrowing after CRT implantation is prognostically important in patients with left bundle branch block and is associated with over 2 times lower mortality rates, whereas other patients receiving CRT do not show similar benefits from QRS narrowing. Additionally, in figure 3, an interesting and potentially important finding of this study is that the degree of change in QRS duration in left bundle branch block is important, with a strong relationship between risk of death and both QRS narrowing and widening. So maybe the answer to what would have been Ashley's question, if you could hear her, would be no. So we're going to attempt to narrow it further.
So I don't know if you can hear me now.
Can we hear Ashley?
Hello. Can you hear me yet? No?
Can we hear Ashley now?
Had enough of me? I broke the mic.
We can't hear Ashley. Okay, so here is a reminder of Mr. Ayub's single point AV and VV optimized 12-lead ECG. So I'm going to ask Ashley to utilize the fusion-based algorithm in this device. And I will explain what she's doing while we go through it. So we'll wait for 1 second because we need to see the programmer screen. So the programmer screen's on and Ashley's going to press perform sync AV CRT. And she's going to program sync AV, which is what fusion-based CRT is called in an Abbott device. Fabulous. So we now have the fusion ECG. It's not surprisingly too different from the previous ECG. Mr. Ayub had a PR interval of 220 milliseconds, and we are AV pacing at 150 milliseconds. So we have actually, in fact, got fusion of his intrinsic at the programmed AV delays, and therefore we do not need to utilize sync AV in this case. So we've now turned it off on the programmer. Fusion-based algorithms are contraindicated in patients with AV block, and as we have seen with Mr. Ayub, he has got first-degree AV block. So now we're going to run through how fusion-based CRT works, as well as other advanced features. So firstly, let's look at conventional CRT pacing. We create full capture of the RV and LV with no input from the patient's intrinsic conduction system. In fusion-based CRT, and as I said before, in an Abbott device, this is called sync AV, we include the patient's intrinsic conduction as additional wavefronts depolarizing the left ventricle. Interestingly, the first case report of a CRT implant in humans was by Kazu in Ren, and he utilized fusion CRT. Their first patient had a PR interval of 200 milliseconds, and they saw most benefit from an AV delay of 140 milliseconds acutely. This patient lost 17 kilograms in just 6 weeks and a move from an MYHA of 4 to an MYHA of 2. So the next potential is to add MPP, or multi-point pacing. And this involves pacing the left ventricle at 2 sites on the same lead, ideally 2 anatomically distant sites. So this means that we now have MPP-LV pacing, plus RV pacing and intrinsic conduction, adding to the activation of the LV also. So I'm now going to ask Ashley to activate. So we'll go to the program screen. Fab, and I'm now going to ask Ashley to activate multi-point pacing in Mr. Ayub, and we can take a look at the resulting ECG once she's done that. So we'll just program that for you. So once you've picked wider spacing for the multi-point pacing, you press program, and then here is the resultant ECG. And this is with the addition of multi-point pacing. And once you can see that, I'm just going to ask the panel and the audience whether they have any thoughts. So panel, just wondering if you have any thoughts about this ECG now that we've added multi-point pacing.
Now see.
So obviously that created a lot of discussion, which is always really good. So as you can see, we further narrowed Mr. Ayub's ECG to 110 milliseconds, and that is 10 less than it was before. And we can also see a shift in axis in lead 1, indicating more contribution from the LV lead. So we think we're going to stick with this ECG. In terms of longevity, each individual is going to show a degree of variance due to impedances and thresholds. And we should be mindful that although all companies now have a version of MPP, they do not all have the same technical characteristics, and therefore some technical solutions to creating MPP can cause significant longevity reductions. So this is the data from a large Italian MPP study called Iron MPP. Overall, they observed a reduction in longevity of 0.4 years with MPP on in Abbott devices. In Abbott devices. Furthermore, with diligent programming of LV vectors, essentially which pole is paced first, and therefore has the automatic threshold management algorithm functional, we see again longevity reductions of about 6 months overall. In Mr. Ayub's case, we have seen a reduction in longevity on the programmer from out of box at 7.1 years, and with multi-point pacing turned on, 6.3 years. Additionally, we have programmed the LV vectors to not include the coil as the anode. Utilising the coil will reduce the impedance of the LV circuit and therefore decrease the longevity. Mr. Ayub will leave with his CRT optimised for CRT response and longevity, and obviously, you will discuss with the patient about battery life versus optimisation. So to recap, you should now see our final ECG for Mr. Ayub. We believe that we have a superb ECG result in Mr. Ayub. But what should we be looking for on an optimised CRT ECG? So a paper published by Sweeney in 2014 may help us answer this question. In their study, they identified 3 different types of ECG that you might create with a CRT patient, and then looked at the anticipated outcomes. They concluded that easily determined QRS complex attributes before and after CRT predicts LV reverse remodeling. Here are the group's different ECG types. The lead they are referring to here is essentially V1, V2. In the red box of the figure, we see our presenting ECG, left bundle branch block, which is negative in V1 and V2. In the yellow box, we have the result of LV pacing on our V1, V2 ECG. In the green box, we have the result of bi-V pacing on V1, V2 again. And finally, in the blue box, we have the result of our bi-V pacing on the QRS duration, i.e. increasing, not changing, or decreasing the QRS duration. And Sweeney et al. Labelled these ECGs type 1, type 2, or type 3. He then also calculated the predicted response probability for the ECG types. As you can see, type 1 ECG created a predicted response probability of 80%, with an LV ESV of minus 16. In the type 2 ECGs, these created a predicted response probability of 96%, with an LV ESV of minus 46. And with a type 3 ECG pattern, it created a predicted probability response of 32%, with an LV ESV of plus 48. What I think you will notice here is that the normalization of ECG type 2, which, to be fair, is not your classical CRT ECG, we sometimes look for, that's more of a type 1. So maybe we should aim for type 2 if you can get it. Bear in mind, type 2 ECG is only possible if your patient has a normal-ish AV node conduction. It's using that fusion of pacing and intrinsic conduction to create a skinny ECG. So panel, looking at our final ECG, do you think we got a type 1, type 2 or type 3 ECG based on the Sweeney paper? Excellent. Hello. So that's brilliant. So we agree. It's a type 2 ECG. And if we look at the Sweeney data, we would hope that we would get a very high response probability. So what have we demonstrated today? We've demonstrated how we can add incremental benefit to our CRT patients through an easily achievable personalisation protocol with clear, measurable targets. In general, this takes less than 10 minutes and is achievable before the pocket is closed. In Mr. Ayoub's case, if we consider the programming choices made and apply this to the clinical papers we've reviewed, we can visualise the potential reduction in the hazard ratio with each step. So on this final slide, if you look at the red arrow, this is QRS duration and hazard ratio out of the box settings. Yellow is with good single point CRT, and green is with the addition of multi-point pacing. So we have seen a great ECG result and some of the evidence base behind that. We have seen and heard about the excellent symptomatic response that Mr. Ayoub has had. We have shown you the practical steps that you can take, and we implore you to consider this approach to help improve your patient outcomes. So I would like to thank Mr. Ayoub for coming today and for helping us out and letting us use him to show you guys how we like to optimise CRTs. And I'd like to thank Birmingham for bearing with us with all the technical problems, and thank Ashley for coping with no mic. But yeah, we'll take any questions if there are any.
Jen will take any questions. Paul, last slide.
Oh, and we forgot to say that as a thank you to the panel for such a good session, we were going to get you all some T-shirts made so we could start a bit of a crew. And they're all in the post.
You got to wave.
Am I on now? Okay.
Are we waving again?
Bye.
I'm gonna go.